Good evening, sir.
Good evening. People are still joining, so maybe within 1 minute we'll start.
Good evening, sir.
Good evening.
Hi, Atma. Good
How are you,
evening.
sir?
Atma, you're here, so you're one of the
Evening, sir.
speakers.
Yes, sir.
So he was traveling, no?
Sir. I have reached to the destination, so I'm free now.
Okay. I think we can start now, so maybe let the people join. So,
Ronak, start the meeting. Ronak, start the meeting.
The meeting has already started. Attendees have started to join. You can start now, sir.
okay, so very good evening and welcome to this second session of this controversies to consensus series, which will be main idea is to discuss some clinically relevant as well as controversial topics in different aspects of the neurology, common neurological disorders, including stroke, epilepsy, movement disorder, and headache. So it's a monthly webinar series on every second Friday of month at 8 p.m. So we will be discussing and trying to reach consensus on some of the controversial topic. So last month we have a topic on epilepsy for the initial monotherapy. And now we move to what happens when the initial monotherapy fails or it is not effective. So whether to go for duotherapy or we have to choose a alternative monotherapy or substitution therapy. So this will be the topic for today's debate. And one of the speakers as for the last debate, Dr. Dinesh Nayak, one of the senior most and prominent epileptologists in the country, who has been trained and worked at Sri Chitra before moving to the Chennai and at present associated with the Global Hospital Chennai. And he is the teacher of many of the epileptologists and neurologists in the country, including myself. So he will be debating on the aspect of the duotherapy after the failure of first thing. And the monotherapy topic, I will be discussing the advantages of alternate monotherapy. As an expert panelist, we have fortunate to have Dr. Radhakrishnan, one of the most senior most neurologists and epileptologists in the country, who has served at various positions, including the director of prestigious Sri Chitra Institute, and at present he is working in a hospital at Palakkad. Dr. Radhakrishnan can be called as the father of epilepsy and epilepsy surgery in India, and he is a teacher of almost all the neurologists and the people who are practicing epilepsy in the country. So I welcome Radhakrishnan sir for the panel discussion. I think Murthy sir probably will not be able to join because of some personal issues. I hope Dr. Gagandeep Singh, who is the president of IN and one of the senior most neurologists, probably joins in the due course. So this is the format. Let us start with the poll. We will have 3 polls. The same question will be repeated at 3 times. The first before the start of debate, second will be after the finishing the 2 debates, and third will be at the end of the session when we have after the panel discussion. So this is the question for today. What is your preferred approach after the failure of the first anti-seizure monotherapy? That is, if you have started one drug in a patient of epilepsy and that is not working. So what will be your approach? The option A is whether it is a duotherapy or add-on therapy, you add another drug. Another option B is alternate monotherapy or substitution therapy, you change over to the another drug. Third is, or whether you would like to refer to a epileptologist for the better control. So that will be the third option. Also, it is equally a valid option. You can choose that. So I will ask the support team to start the poll, please. So you can vote in choose one of the options in 15 seconds. Okay, if everyone has voted, can you show us the results, please?
Sir, everybody is voting right now. Out of 53 participants, 29 people have voted. So shall I end the poll now or shall I wait?
Let us wait for maybe 10 seconds more. I request everyone to vote and give your choice, because that is the what we have been practicing in all our daily clinics. Okay, let us see the results.
Sure, sir.
Okay, so 79 prefers duotherapy, only 21 are preferring alternate monotherapy, and none of them will refer to a epileptologist. So that is what is the poll says. So Nayak sir is already in the flag position. So I think we will start the debate, and I must confess that it is a debate, or it is a between David and Goliath. So Nayak sir is the I think Colossus in epileptology is my teacher. So he always starts with a position of advantage. And let me see if I can try to displace his position from the duotherapy. So, sir, over to you. You can start.
Thank you. Thank you. Thank you very much, Dr. Rathod, for that very nice. First of all, the very kind introduction. And it's always a pleasure and a privilege to be with you. And it's a great honor to be with Professor Radhakrishnan, my mentor, teacher, mentor, and mentor for all of us. So great, wonderful. Thank you. And yeah, I think right now my physical stature is like David, that's for sure. And let me see whether I can, and although I'm starting from a position of strength, well, you never know. You know, at the end of, I'm sure that Dr. Rathod will be able to sway a significant portion of people to take up alternate monotherapy as a good option for people with epilepsy where they have failed the first anti-seizure medicine. So let us see whether I can kind of convince people about this, that what happens if you have started a medicine, a monotherapy for a patient with epilepsy, and then unfortunately does not respond to that. So what are the choices? And are you going to add another medicine, or are you going to substitute it? So I've been asked to talk on the argue for duotherapy, and so that's what it is. And the poll also said that most of you, the participants, seem to prefer duotherapy, but there must be some basis for that. And there's also a very good basis for alternate monotherapy. So I think there's no clear-cut this thing, but I think we should debate these issues, and we'll have to try to convince people as to, you know, at what point you would use duotherapy, at what point you would use alternate monotherapy. So basically, we start off with the two dogmas, which has been there for the last 40 years. And this dogma is the first of the dogma is that treatment must always begin with monotherapy. That is the first dogma. And the second one is to try at least 1 or 2 or even 3 monotherapy trials before embarking on the adjunctive anti-seizure medicine trials. This has been there from 1979 onwards for the last more than 40 years now. And this may need some kind of a reconsideration, and I will try to propose that. We'll start off with a case. I mean, this is a real life scenario. One of our patients from our center, a 7-year-old boy, seen long back, I mean, many years ago, who's otherwise normal, but for the last 1 year at the age of about 7, he started having episodes of stare with unresponsiveness, side-to-side eye movements, and lasting for briefly 15 seconds, and then he would sleep off. And he's otherwise a normal boy. And obviously, this is a straightforward patient, case where, this is a focal seizure with impaired awareness, probably posterior head region occipital because of this nystagmus and all that. And quite rightly, the EEG showed bilateral occipital spikes attenuating to eye closure. So this is definitely a kind of a benign occipital epilepsy syndrome. The neuroimaging was normal. So this is a BOE. So that there's no doubt about it. Now, what do we do? So what we did was we thought, for benign localization related childhood, benign focal epilepsy syndromes or self-limiting focal epilepsy syndromes of childhood, generally most of the drugs are useful, but I think valproate is one of the drugs that we think is most appropriate. So we started with monotherapy with valproate at 30 milligram per kilogram, 600 milligram per day. Continue to get 6 seizures, continue to get episodes of seizures, 6 episodes in the next 4 weeks. So the child could tolerate this medicine. So we increased the dose to about 800 milligrams per day. That would come to roughly about 40 milligram per kilogram. And again, he continued to get seizures 6 over another 8-week period. He had no problems because of the medication. He was well tolerated. There's no adverse effects. So obviously here, the first monotherapy valproate was not efficacious. We felt that the valproate should have worked. It was an appropriate medication for that particular syndrome, but in this boy, it didn't work at doses which are generally considered as adequate doses. Although he didn't have any adverse effects and he tolerated it well, we did not push it up further. So what do we do now? At this point. So these are the questions that generally come up. Do we substitute with another anti-seizure medicine, which is otherwise called a substitution monotherapy, which Dr. Rathod is going to talk about? If you want to substitute, would you choose an older anti-seizure medicine or a newer anti-seizure medicine? Or you want to add another medication to the already existing medication? So, and if so, then would you choose an older anti-seizure medicine or a newer anti-seizure medicine? So you see, these are the questions that come up. And then if you're choosing another anti-seizure medicine, whether it is as a substitution or an add-on, would you choose a sodium channel blocker? Would you choose a medication with multiple mechanisms of action? So these are the questions that generally have to be answered or addressed. And that's the whole talk about. So the point that we have to understand is that what is generally, when you start a drug, an anti-seizure medicine in a newly diagnosed epilepsy, what really happens? So when you start the first medication, first anti-seizure medicine, generally the response is very good. And in this landmark study in Brody et al., you see that 47%, nearly half of the patients responded to the first monotherapy trial. So that's the very, very important point. So half of them respond well. But then the response rate to subsequent therapies or subsequent monotherapy trials is not very good. it just drops dramatically. The response to second drug comes down to just 13%. And then the third and the fourth drugs, the response rate is even lower. So that's the point that we are looking at. So you see that if the first monotherapy trial fails, then you're really in a quandary there. Do you want to put a second drug where that, in the sense you trying to try a second monotherapy trial, because with this data, that maybe the second trial may not have the same efficacy as the first one. The first one has already failed. The chances of the second one failing is much higher, actually. And the third one, obviously. So that's the question that we have to ask. And all these patients, most of these patients had received, the first-line drugs, carbamazepine, valproate, or the second-line drug, lamotrigine. So that's what it is. And again, the same cohort was added on, and they had a longer period of follow-up. You could see that they followed up for up to 26 years. And a larger group from 470, it became 1,098 patients who were followed up. And these are the four patterns that you see, what happens to these patients. A third of patients would go into early sustained freedom of seizures. Some of them will take a little time, but then they go into sustained seizure freedom. So that means about nearly 60% of patients would become seizure-free ultimately, either early or after some time. So that's very important. A group of patients would never achieve seizure freedom, whatever you do. So that's a group which is about 25%. But interestingly, there's another group which keeps fluctuating. They respond for some time, they don't respond for some time, they again start responding. So that kind of a fluctuating group is there. So this fluctuating group is a very interesting group. But our point here is that we are talking about the first medicine which fails. So that's something that we have to look at. So the things have not really changed much over the decade since the first result that came out, the first trial in 2000, and then the next trial that came out in 2012, the follow-up study. You see the response rate to the first monotherapy trial, whether it is a new drug or an old drug, not really much different, 47 and 49.5%. So not much of a change has happened despite us having multiple newer anti-seizure medicines. So that's a very interesting point. Is also a point of a sobering thought also, that the anti-seizure medicines have their own limitations. Now, when you have to choose an anti-seizure medicine, obviously, these are the very important points that we always look at: the seizure type, the epilepsy syndrome, the efficacy in our country, very, very important, cost, and very importantly, the pharmacokinetic and the pharmacodynamic profile, adverse effect profile. And so you'll have to choose a medicine which fits and which also fits the patient. So it's not enough for the medication to be efficacious, but it also should be appropriate for the patient, must fit the patient's pocket, must fit the patient's medical conditions, etc. So a lot of things are there when you have to choose the medication. So you have to choose the first medication right. So what happens, what do you do when the first anti-seizure medicine fails? For example, what we had in our patient, which we started off with. So does the patient actually have epilepsy? That's a very important point. At every point, you'll have to ask this particular question, because a third of patients, or not a third, about a fourth of patients whom we are treating as epilepsy may not actually have epilepsy at all. So that's a very important point. Is the patient having seizures while taking the appropriate first-line anti-seizure? You think that this particular drug should be working for that particular syndrome or the seizure type. So that's very important. So is it appropriate for that particular patient and the seizure type? Now, is the anti-seizure medicine at the appropriate blood level? And if the blood level is lower, then you actually increase the dose. And if it is low, then you have to also suspect whether the patient is actually compliant or not. And you can push up the dose to the maximum tolerated level. So these are the strategies that we adopt. Now, obviously, there are a lot of advantages for monotherapy: lower cost, lower risk of adverse effects, better compliance because you're only on one medication, avoidance of pharmacokinetic and dynamic interactions. And you know that initial monotherapy seizure freedom rates are at about 50%. So that's the plus point for monotherapy. But not necessarily, because you see, why duotherapy instead of sequential monotherapy? There are some advantages for duotherapy over sequential monotherapy, because the newer anti-seizure medicines have better favorable characteristics because they have fewer pharmacokinetic and pharmacodynamic interactions. And there is a possibility of synergistic actions and efficacy, which is the basis for the so-called rational polytherapy. And all the newer anti-seizure medicines were first used and approved for as adjunctive therapy. Always, it starts off as adjunctive. It's only then later on that they are approved for monotherapy. So they already passed the test because they already were used as adjunctive therapy, which means they're added on already. And when they pass that add-on test, then only they are approved later on for monotherapy, which means that they already, which means that the efficacy is already established. And that's the reason why they have been finally approved for monotherapy. So you see that there's an advantage with that also. So let's look at some of the trials. You know, this is the one of the, again, a landmark one. Epilepsy after the first drug trial failed, substitution versus add-on. Again, Brody's group. And you'll see that this is what happens with the first one. As we said, 47% respond to the first drug, and you see this. But as you go, you use the second drug, third drug, you see the response rate, the efficacy starts coming down dramatically, and it's practically nil when it comes to the fourth trial. And slowly the adverse effects also keep increasing, and the seizures also, are inadequately controlled. So that's what happens. So this is clearly evidence that, substitution monotherapy generally doesn't work that well. But you need to know at what point you can substitute a drug and at what point you need to add on. Now, if the reason for failure is inadequate control or intolerable side effects, then a substitution therapy helps, because if it is inadequate control, then you can use another drug that will help us to control better. If it is because of intolerable side effects, then it's good, because then the response rate is very good. On the other hand, and also if there's some idiosyncratic, you use the smallest dose of a particular drug and there's some idiosyncratic reaction, then you can change the drug to another monotherapy trial, and then that response rate is better, and so on and so forth. So if the problem is because of inadequate control, then a second drug doesn't work that well. On the other hand, if the first drug has intolerable side effects or has some idiosyncratic reactions, then a substitution monotherapy is beneficial. So that's the point that they want to make. And you can see here that, the add-on, the response rate was much higher than with substitution. See, add-on, it was 26% became seizure-free, whereas only 17% became seizure-free when it was substituted. So that is the point that we have to see, that the outcome is better for add-on than. And if you choose a combination where there's one drug which is a sodium channel blocker and another drug which has multiple modes of action, that combination is superior to other combinations. So this is another aspect of how do you combine medication. And there are a lot of combinations like this, and it's a good thing to have this chart with you in the outpatient so that, this is a ready reckoner chart where you can actually choose the combinations, the so-called rational therapies. So combination therapy is more effective when prescribed immediately after the first anti-seizure medication failed than when delayed until treatment with substitution anti-seizure medicine also failed. So early add-on seems to have a beneficial action as compared to adding on after, say, a second trial has failed or a third trial has failed. Now, let us look at some of the evidences. Of course, I mean, there are some 2 negative trials. I'm going to go into that. Now, this is the first one that was an adjunctive therapy with partial therapy. What happens when the first drug failed? And this is a failed first monotherapy, 157 patients. They were randomized to either an alternative or a duotherapy. So alternate monotherapy or a duotherapy. And the cumulative probability of remaining on treatment, that means the tolerability of the drug, that's good because 55% remained on the medication, and duotherapy 65% remained. So that means there's no problem with tolerability of the medication because they seem to be on the medicine even at the end of a year. But the seizure freedom rates were almost the same. There's no difference between monotherapy and duotherapy, both in terms of efficacy as well as tolerability. So this is a negative trial. There's not much to choose between the two. Again, another one, again, this was in 2014, early add-on versus alternate monotherapy. 143 neurologists randomized about 264 patients to either alternate therapy, monotherapy, or add-on therapy. And they looked at the outcome at the end of 6 months of treatment. So they followed up for another further period of 2 months, and the percentage of seizure-free patients during a 2-month period after 6 months of treatment, that was the primary outcome, seizure freedom. The secondary outcome was 50% reduction at 6 months of treatment, tolerability and quality of life. There's not really much difference between the two groups, the alternate monotherapy group or the early add-on group. They were not significant. There's no significant difference in any of the parameters. The primary endpoint or the secondary endpoints, both were equal. So again, here, this is a negative trial. But this is for a very short period of time. The duration of the whole study was only for about 8 months. But you see this 2018 study, which is on a larger number of patients and over a longer period of follow-up, nearly 3 years of follow-up, 502 patients failed to respond to the first anti-seizure medicine, followed up for 32 months. They had 3 groups. The first group, they just increased the anti-seizure medicine dose, the first anti-seizure medicine dose. The second one was they combined another drug. And the third one was alternate therapy. So they switched. So they increased the first drug. One group had an increase in the dose. The other one, they added another drug. And the third one, they substituted the drug. And here there was a very clear difference because the combination clearly was superior to either substituting or increasing the dose of the already existing medication. So that is very clear. This is the best evidence over a longer period of time to show that duotherapy is superior to either increase of dose of the monotherapy or changing one monotherapy to another monotherapy. So that is very clear evidence. And the various drugs that they have used, you can see in this list that many of them were newer anti-seizure medicines. And so that's what it is. So it's very clear that combination therapy is superior to increased dose and alternative therapy. So what do you mean by this rational combination therapy? Now, is it really rational? So basically, it's a theoretical concept. What we think is that it is you intentionally choose a second drug to enhance the seizure control. And so what is that second drug? It obviously, you must choose a second drug whose mechanism of action is different from the medicine that the patient is already on. So that is what it means. So varying mechanisms of actions. So the outcomes, the probable outcomes of combining 2 medications are these. So either 1 + 1 becomes 2, which is called additive. 1 + 1 can become more than 2, which is called synergistic or supraadditive. On the other hand, 1 + 1 can actually become infra-additive. It can become negative, become less than 2. So that's what is called infra-additive. So this can be either in terms of their clinical efficacy or in terms of their adverse effects. So these are the two things that you have to look at: the efficacy. You can have an additive efficacy or a synergistic efficacy, but you could have a synergistic adverse effect also, or an infra-additive adverse effect. So whatever it is. So these are the various combinations that you can get. Now, the advantages of rational polytherapy is that it possibly increases efficacy. The possible disadvantages are interactions. And then I was mentioning about this additive or even supra-additive side effects. So it's not very, there's no single answer to decide whether monotherapy or polytherapy, and some combinations are rational, others are clearly not. For example, phenytoin and carbamazepine, not a good combination because both are sodium channel drugs and they have additive side effects and also adverse pharmacokinetic interactions. Phenobarbital with benzodiazepine, they have synergistic side effects because they are complementary action on the GABA-mediated chloride channel. So these are drugs, the no-go combinations. So that's very important to remember that do not add these two medications. And the best evidence for rational polytherapy is this. You can see that when you use just phenytoin and just use carbamazepine, the seizure frequency reduction is just modest. But moment you add, this is a valproate plus lamotrigine. When lamotrigine is added to valproate, the seizure freedom or seizure reduction was dramatic. And when the lamotrigine was withdrawn, then valproate's efficacy alone as monotherapy was not that good. So these combinations of valproate and lamotrigine had a very good efficacy in terms of marked reduction of seizure frequency, as opposed to using valproate only as monotherapy, as opposed to using only phenytoin or carbamazepine as monotherapy. That's the point. So this is the best evidence that you could get. And there are several synergistic anti-epileptic or anti-seizure medication combinations, and there are lots of them. These are some of the preclinical synergistic anti-seizure combinations. And there are some clinical evidences of these rational polytherapy combinations, valproate, ethosuximide. So many of them are there. And in the modern era, I mean, in the third generation drugs, lacosamide with levetiracetam, lacosamide with other anti-sodium channel blockers, so many of them are there. So that's something that we have to see. And this is also true for children. So again, it's been shown that valproate and lamotrigine combinations better than others. 2 drugs are definitely better than third. So what did we do for our patient? So we added, because, remember that we increased valproate to 800 and the child was still getting frequent seizures. So we just added lamotrigine. And over the next 8 weeks, we titrated lamotrigine to reach 5 milligram per kilogram. And the child tolerated it well, no adverse effects. And in the initial period of titration, he had 3 more seizures. But once lamotrigine reached 5 milligram per kilogram per day, he's become seizure-free. So he became completely seizure-free. And what we did was, when he was stable, then we started reducing the dose of valproate from 800 to 600, then 600 to 400. And finally, we just kept it at 200 milligram. So low dose combination therapy, absolutely no problem. So that's what it is. So early add-on has worked in this boy. We used lamotrigine and valproate combination, which has got a lot of, there's evidence-based. And the first well-chosen anti-seizure medicine was ineffective, but well-tolerated. So if you remember the Brody's, this thing that when the first drug is ineffective, then it's better to add a second drug. But if it is not well tolerated, then you can have a substitution. So that's what it is. So combination of valproate was synergistic. So that's what it is. So in summary, reasons to add on versus switch. Add on, if the first drug was inadequate in controlling the seizure, poor tolerance to the first anti-seizure medicine, no anticipated drug interactions, patient risk averse, or they're worried about, they don't want a second seizure to happen at all. So it's sometimes the patients are very, very worried about another seizure or the consequence of a seizure. So it's that those are the times when you don't want to take a chance. You can actually add 2 drugs and then get controlled and partial control with the first anti-seizure medicine. If again, these 2 are the same, but you have to switch if there's poor tolerance to the first anti-seizure medicine. And if the first anti-seizure medicine has disadvantages, or rather, in other words, if the appropriate one has some disadvantage, then you can use another anti-seizure medicine. If drug interactions are expected, and pregnancy, so that's something that we would like to use one anti-seizure medicine, and seizure exacerbation not likely. So in these situations, you would use switch. And I would end my talk by this argument that it's a very nice statement. If it is possible to combine 2 drugs at lower doses than the toxic dose of either with better efficacy, the overall drug load and thus the risk of toxicity may actually be less than with the high level of a single drug. So polypharmacy need not be such a pejorative term. So that is, I think that's well said. And that's what we did for our patient. What we did was, he was on 800 milligram of valproate. And finally, it ended up with, 100 milligram of lamotrigine and 200 milligram of valproate. And he's all right. So that is, so the low dose of 2 drugs is less than the drug load. The drug load is less than the high level of a single drug. So thank you very much. These are my arguments for early add-on therapy, duotherapy. Thank you very much.
Thank you, sir. So as what happens in any debate or when you write an article and you are trying to advocate the one approach, probably you show the one side of the coin and present the evidence favoring that side of the coin, and very conveniently forgetting that the coin has 2 sides also, which probably is my duty to remind you, all the audience, that there are 2 sides of the coin, and what I will be doing to present you the second side, and then you can choose what will be the best option for patients who failed initial monotherapy. So this is, I will be discussing or advocating the use of alternate monotherapy or substitution therapy after the failure of initial anti-seizure medicine therapy. So this will be what I will be doing as what will be the initial advantages of monotherapy. What we will be doing, that is, after the failure of first monotherapy, what are the current practices and what is the current evidence? And then the rationale for alternate monotherapy, what we can look beyond the evidence, and then probably some practical tips. So over the years, the monotherapy has become the dogma in the initial management of epilepsy. That's what we are discussing, that in this part, that is what it's initial management of the epilepsy as a first drug. So this was not the situation till 1980s. Until early 1980s, combination therapy was a rule in epilepsy. And it was believed that the more number of drugs will produce a better seizure control. And that was what Naik sir was highlighting, that more drugs probably you add on early and you are likely to produce a better seizure control. And this was the practice till, I would say, 1985. And this was the study from the Netherlands, where they collected a blood sample of different patients of almost 2 lakh patients. And out of which 1,200 1,000 patients were of epilepsy patients. So when they basically collected the sample to see the blood levels or monitor the blood levels. And on these 12,000 epilepsy patients, the mean number of drugs were 3 drugs. So that was what it suggests, that a majority of the patients were on polytherapy, and their mean number of drugs they were taking was 3. So this was the standard in 70s and 80s, and multiple or polytherapy was the rule. Subsequently, people started realizing the side effects of the anti-epileptic drugs, and especially this was with the older drugs starting from the early 80s. Many side effects which are now well established in the practice, starting from the enzyme induction, peripheral neuropathy, bone disease, megaloblastic anemia, endocrine disturbances, and these side effects were realized. And it was believed that, and one of the reasons cited for this side effect was unnecessary polytherapy was considered to be one of the main reasons for this chronic anti-epileptic drug toxicity. With this realization, people started realized the importance of the monotherapy, and they started using monotherapy for the seizure control. So this was the earliest study in 1980, published from the UK. So this investigator, basically Dr. Chadwick and Reynolds, they managed 31 patients with monitoring of the therapeutic drug levels and with phenytoin alone. And out of these 31, 28 patients could be managed with the initial, only the monotherapy. So that what was believed that duotherapy was effective, now it was getting switched over to monotherapy. And subsequently, many publications came out starting from the 1980 to early 1990s that polypharmacy produces major side effect. Polytherapy is more difficult to manage, and majority of the patient can be controlled with the monotherapy only, and which led to the change in the practice for using multiple therapies to a use of the monotherapy as the initial therapy in epilepsy. So it is always better to, or people realized over the years that monotherapy should be the goal in the case of all the epilepsy patients. So approximately in these all study, patients were on multiple therapy. They tried to switch over to monotherapy, and more than 80% of the patient could be switched to the monotherapy without affecting the seizure control. So obviously monotherapy offers certain advantages, and it has been shown that monotherapy is effective in most of the patients. That's what we will see in the next few trials. Monotherapy is obviously better tolerated. At least you can avoid the idiosyncratic reaction and additive side effects of the more than one medicine by adhering to the monotherapy. Obviously, monotherapy is better to titrate, and there is an ease of administration, and it facilitates the clinical management. It is easy for clinician to manage monotherapy rather than duo or polytherapy. Obviously, less the number of drugs, it improves the compliance. Less the number of drugs, the drug interactions are less, and obviously costs are also reduced, which is important in our country. And more importantly, which I believe it is a feel good for the clinician as well as for the patient, that patient is controlled with the single drug rather than taking a multiple drug. So once the patient is taking multiple drugs, as a clinician, I always have apprehension that probably this is difficult to control epilepsy. So overall, these are the definite advantages of the monotherapy. And which this graph Nayak sir was showing that you can use some polytherapy if there is a definite supra-additive or synergistic effect. And till now, at least in the clinical practice, in the well-tolerated trial, evidence is largely lacking for any synergistic effect of the anti-epileptic drugs or anti-seizure medicine. So whatever is based on the animal studies or anecdotal reports rather than the clinical hardcore evidence that there is no synergistic effect and drugs are rather additive. So let us see how common is the failure of monotherapy. In what proportion of patients you will require to change or to add the therapy. And this is mainly has been shown by Nayak sir. It mainly came from this Glasgow study that approximately after the initial therapy, 50% of the patients can be controlled with the 45 to 50% with the initial monotherapy. So there is a large number of half of the epilepsy patient will not respond or will fail to the monotherapy. And these are the different anti-epilepsy. Now I want to highlight this specific point here that when you tell that these are the second monotherapy or third monotherapy, this is not the case. These are the drug regimes which have failed and not the monotherapy which has failed. So once the patient fails the monotherapy, these are the whether you try either as a duotherapy or either as a monotherapy, only a small percentage, maybe 15 or 11 to 15% of the patient will respond. So it is not the failure of the single monotherapy. It is the failure of, in this study, it is the failure of the subsequent anti-epileptic drug regimes, and which may be a monotherapy or which may be a combination therapy. So to tell that once you face the first monotherapy and then the second and third monotherapy, chances are low. That is not the crux of this study. The study shows that whatever regime you use, whether the combination therapy or monotherapy, this much is the chances and not the particular monotherapy. So initial monotherapy is effective in 50% of the patient, and then another 50% you will require to change or approach, whether it's the alternate monotherapy or combination therapy. So what is the practice in the different countries or different scenario? Although obviously data is lacking in our country, but this was the survey done in the early 1998 from the 500 clinicians from the 14 European countries, whether they will use monotherapy or duotherapy. So you can see the response was variable. In some countries like from the Syria and Greece, Turkey, approximately 1/3 to half of the clinician preferred alternate monotherapy, while in the Israel, Spain, and France, approximately more than 3/4 of they preferred the alternative therapy. So clearly divided opinion again. But when you see that the survey from the United States, what should be the second line, that is the additional trial after the failure of the first monotherapy. So you can see that approximately 43, and these are the epileptologists, epilepsy experts, 43 of them initially choose the monotherapy, and then after the failure of the monotherapy, the combination therapy is chosen by only one, while the 98% of the epileptologists or clinicians have preferred the alternate monotherapy. So that clearly in the data, or at least in the US, there is a trend for the using alternate monotherapy rather than the duotherapy. So this is what is the practice, what is the clinician or practice. Is there any rationale for this practice, or is there any evidence for this practice? So there is, if you see the same Glasgow study, if you see how many patients were at the end of the follow-up, how many patients were actually on the monotherapy. If you take the whole cohort of, let us say, 1,800 patients, so of this, approximately 80% were on anti-epileptic drug monotherapy. Subsequently, at the end of last follow-up, whether they are controlled or not controlled. So this also suggests that there is a practice of using alternate monotherapy, or mainly a monotherapy, even in this largest Glasgow study. So this Naik sir has also shown, and then again to highlight what is the proportion of patient who fails the therapy. So these are not the individual monotherapy trials, but these are the individual drug regimes, whether in the monotherapy or duotherapy. And here, what is the point to remember that what is the failure or the reason of the failure, which decides the subsequent outcome, whether you use the monotherapy or duotherapy. If the patient had inadequate control with the initial therapy, that the seizures are not controlled, chances of subsequent seizure control are low, with whether you use monotherapy or duotherapy. But the patient has intolerable side effect or the allergic reaction, then chances of so this is that drug has not failed completely, but because of the other reasons, drug has been not effective or has been withdrawn. In those cases, chances of the seizure freedom are more. So it is the cause of the failure of the first drug which determines the outcome, rather than choosing whatever the drug you want to choose. So that is important when we try to choose what is the next line of treatment. So in this same study, Patrick, Cohn, and Brody, the same study, they compared whether you use add-on therapy or substitution therapy. This was in the patient who have failed the initial first drug. So if you compare these two groups, whether you add the therapy or substitutes, there was a minor difference, but it was not statistically significant. So there was no significant difference in this outcome, whether you use the alternate therapy or the substitution therapy. This was another pragmatic randomized controlled trial where the 157 patients were who have failed the initial therapy were randomized to the alternate monotherapy or add-on therapy, and they have a large follow-up of long-term follow-up of 1 year. So what was the remaining or the retention rate So there was no statistically significant difference whether you use the add-on therapy or monotherapy. And similarly, the chances of seizure freedom, which whatever the approach you use, was not different, clearly indicating that clinically or the statistically or evidence-wise, there was no difference between the two approaches. But if you see the one of this largest study of this alternate monotherapy versus substitution, add-on therapy, this was approximately 600 patients, out of which around 200 patients received substitution and 387 patients received add-on therapy. So this was a large group of approximately 600 patients, which was again, it was an observational study. There is no hardcore definite randomized control trial. And what was the outcome in this? Seizure freedom at 3 years, if you take, this was the substitution therapy versus add-on therapy, and substitution therapy or alternate monotherapy were significantly better in both as well as seizure freedom as well as the retention rate. So this is the one of the study, although it is an observational study with its flaws, but it clearly showed at least that alternate monotherapy is a better effect. It is more effective as compared to add-on therapy. And now if you see that this is the largest, again, latest study published in this March this year from the same Glasgow group, where approximately 1,800 patients where the first monotherapy has failed. They tried the second anti-seizure regime. So you see the second medicine regime, it is not the monotherapy or substitution in approximately 500 patients. So in these 500 patients, 31% of the patients were switched over to monotherapy, and the 69 or 70% patients were added to the second medicine. So what was the outcome? If you see, in the seizure freedom, in both the group of patients were nearly equal, 20% and 21%. So there was no significant difference between the two, and this was a large study of. So the majority of this observation large study has shown either no difference between the two approaches, or at least has shown some benefit. At least one of the study has shown a benefit with the alternate monotherapy rather than the add-on therapy. So there are certain facts which we need to highlight. There are proven advantages of the monotherapy. Monotherapy definitely has proven advantages. There is a definitely lack of very good evidence and comparative trial. Overall data suggests either there is no difference or that suggests that alternate monotherapy is better. Then we have to remember that there are the definite studies, and at least the SONAT trial, large trial, have shown that all the drugs are not equally effective. There is a differential efficacy of different drugs. So that is what we can choose. So we have to decide. So to give you this evidence of differential efficacy, this was the SONAT-1 trial in focal epilepsy, where the carbamazepine was compared with all the other drugs. And it was found that carbamazepine, at least efficacy-wise, carbamazepine was better than all the other drugs. Although lamotrigine was better tolerated, but efficacy-wise, carbamazepine was a better drug. Similarly, now recently published SONAT-2 trial, where they compared lamotrigine to levetiracetam and zonisamide. Here also the differential efficacy was proven because lamotrigine was found to be superior and cost-effective as compared to levetiracetam and zonisamide. Same thing holds true for the generalized epilepsy. The valproate in the SONAT-1 trial was found to be efficacious as compared to lamotrigine and topiramate. And similarly, in the SONAT-2 trial, valproate was definitely shown to be superior to the levetiracetam. So there is a definite evidence that drugs have a differential efficacy, and that means that if one drug fails, that doesn't mean that other drug and the monotherapy is not going to work. So anti-seizure medicine have differential efficacy, and failure of the one drug does not mean that the other drug will not be effective as monotherapy. So that thing we have to keep in mind. Why clinicians use duotherapy, and this is a usual practice in India also. Why we want to use a duotherapy when we can do away with the one drug? So purely, I think there is no scientific evidence. Mainly in all of the clinicians in India is very busy, and probably related to, and this is very provocative I'm making, mainly people are lazy to, if you want to change from the one drug to the second drug, it requires a longer prescription, and you require some of, you used to use your mind also, whether you want to use which drug to change and which drug will be more effective. In the case of duotherapy, it is very easy. You can continue the same medicine, and you add another medicine in one line. So that means that it is clinicians do not want to come out of their comfort zone because of they want to use the easy and safe route. And because of that comfort zone, I think majority of the clinicians are using duotherapy rather than the monotherapy in spite of its proven advantages. Naik sir has put some debate points. So which it has been shown that sequential monotherapy trials are less effective, which I have told you that it is not the sequential monotherapy trial, but these are the sequential drug regimes, not the monotherapy trials as such. And then many people cite, and when they use some of the newer drugs they promote, then they tell that if you use early in the course of the disease, it is more chances to work. But that is a natural history of the disease. Okay, so if you use initial as a second drug, whether it's use a monotherapy or whether you use as a add-on therapy, chances of working as a second trial are much more than a third trial or fourth trial, whether you are using monotherapy or duotherapy. So that doesn't mean that if you use early combination therapy, it is more likely to work. That is not the case. If you, whatever the number of failure of the drugs or number of failure of the regime, chances of subsequent seizure outcome will be obviously less. So if you use a duotherapy in the early course, obviously you will, there are chances of success is more, but the side effects also will be more. So that we have to keep in mind. Rational polytherapy, when we talk, it is usually always in the context of a drug-resistant epilepsy. Rational polytherapy is not when we use when the first drug fails. So when you want to combine as a duotherapy, or when you are planning to choose as a duotherapy, then you want to use a definition or want to use a debate of rational polytherapy. But here it is not the debate of using the whether which drug or which is the rational combination. The debate is whether you want to use the one drug or add another drug. So this concept of rational polytherapy is probably not useful in this context of the debate. And there is obviously no data to support one view over the another view, or the data is that rational or monotherapy is better effective. So what I want to make a case for alternate monotherapy is that proven advantages of monotherapy, obviously, which I have narrated. There is no difference in the efficacy between monotherapy and duotherapy. And obviously, if at all evidence is there, it is more in the favor of monotherapy. Majority of the study have used monotherapy as the preferred choice. And we have to use that drugs have differential efficacy. So that means that if one drug fails, you can always go for the drug. So that the alternate monotherapy should be the standard of care after the failure of the first anti-seizure medicine. And it should not be straight away combination therapy or duotherapy, which is have a side effect and which probably has a may not be comfortable for both the patient as well as the clinician. So I urge you to move from your comfort zone of duotherapy, give some time to the patient, lose your laziness, and choose the monotherapy when you are come across a person or a patient who failed the initial monotherapy. I think with that, I would like to rest my case, and thank you very much for your kind attention. So I think we both of us has made a case, and so before going to Radhakrishnan sir for his views, I think we can have a poll again to see whether the what is the result of this David versus Goliath fight. Okay.
This is
So can we have the poll?
Sure, sir. I'll just launch the poll now.
Okay, so now I will request everyone of you to poll these same questions. What is your preferred approach after the failure of first monotherapy? Whether you want to use add-on therapy or duotherapy, whether a substitution or alter monotherapy, or whether you want to refer to an epileptologist. So please, you can choose on your screens, and you can vote. This will be interesting.
but you made some very good points. Let's see.
Okay, if people have voted, then we can show the results.
Not even, sir, 50% have voted. Shall I stop now?
No, so I will urge everyone who are listening to that, at least please vote. Nobody's, this is a blinded voting. Nobody is going to see whether you voted on for which favor. Your results will be anonymous. So request everyone, people have switched on the monitor and I think moved away. So request everyone to vote, please. Okay, after 5 seconds, we can show the results.
Okay, sir. I'm stopping the poll now.
Okay.
So as panelists, we are not allowed to vote. So
Okay, sir, still you are in majority therapy, but I think from
the people are still
16%,
lazy. That's the problem.
16% to I have 15% to I have moved to 33%. So
Yeah,
more than double. More than double,
it's
sir.
double. And I think you're definitely shaken a few from their comfort zones. That's very
And sir,
important.
2% has mentioned that they will refer to epileptologist. That's also a good sign.
okay. So I think with this debate, obviously there are always two sides of a coin, and ones who fit to all approach probably is not justified. We have to take what is the clinical syndrome and what are the drug failed. So I think we will ask Radhakrishna sir about his opinion on this debate and what he thinks of the topic.
First of all, congratulations to both of you. It was a very good debate, one of the best I have heard on this topic so far. And then as Dr. Atul mentioned, there are two sides of the coin. But the problem is when you toss the coin, it may be either head or tail. That's the situation. What both of you presented is based on the clinical trials. And we should remember that clinical trials are done on a group of patients. But when a patient is sitting in front of you, you will have to translate that information to an individual patient. That's where the problem comes into. So how much of that can be individualized or extrapolated? That is a question which you have to decide. And as happens in most of the debates, both of you are right and both of you are sometimes wrong also. There is no absolute answer to this question. For example, what approach I follow is that when you start a monotherapy, that initially, as Dinesh mentioned, having verified the diagnosis of epilepsy, verified that you have chosen the appropriate drug and you have administered to the appropriate dosage. That's what I call monotherapy. In addition to all these, what you call the patient-related and drug-related factors, in a developing country scenario, we have to also look into the other 3 or 4 A's, what you call the availability, affordability, and acceptability also. Because since anti-seizure medication treatment is prolonged, unless you get the patient also into the picture, discuss with him the scenarios and why you're doing that. Without proper counseling, the non-compliance is unlikely to continue. So that's one point which I wish to add. I think if I do that, I may end up with in 3 or 4 scenarios. Number one is that to the first drug, the patient develops a serious undesirable side effect, like a drug rash or even a pancreatitis sort of thing. That means this is evidently a situation in which that drug has to be withdrawn and has to be substituted by another drug. So there is no option other than for sequential monotherapy. So that's a situation in which we will not have any kind of debate. The other problem comes into, the patient has got a partial response, maybe, but it's not optimal. Here, what will you do to the first drug? And second is, as Dinesh mentioned, the patient did not have any response to the first drug at all, but there are no undesirable side effects. And the third one is patient is not tolerating the first drug. Then again, that last scenario also we'll have to go in for a sequential monotherapy. With respect to the second and the third, whether there's a partial response, here the issue is that, suppose that let's say that the patient had something like a 40 to 50% reduction in the seizure, but is not satisfied then the question is whether you want to replace it with another drug or you want to add on another drug. The problem of replacing with another drug or going for a sequential monotherapy, I mean, it's better to play with a known devil than an unknown devil, so that you don't know whether the drug which you are going to start will be less effective than the first, or it produces an undesirable side effect. If that happens, you will most likely lose a patient. He may go elsewhere because you already done 2 trials and still he is not controlled. In such a scenario, I would prefer to add on a drug, like as you did, for example, with valproate. There is a partial kind of response. Then the adding up a small dose of lamotrigine would be more desirable than withdrawing in and replacing it with other drug, because I don't know whether the second drug is going to be as effective as the first drug or may produce undesirable side effect. And regarding the third scenario, where the first drug is absolutely not effective, as the case scenario which Dinesh presented, then I add up a second drug, and as here the lamotrigine was added, the patient became seizure-free, and the first drug could be considerably reduced. There the question arises, if Dinesh had withdrawn that 200 milligram valproate also and kept him on lamotrigine monotherapy, possibly the outcome would have been the same as happened in some of the initial trials which Brody did, where that duotherapy was effective also when that one drug was withdrawn, especially the lamotrigine was retained and valproate was withdrawn. So that's a scenario in which you have to individualize after discussing with the patient. That's the way I would like to approach, and each of these levels, the patient's affordability and acceptability should be taken into consideration. As a study which we did initially, what you call the pharmacoeconomics with respect to the therapy, duotherapy definitely escalate the cost of the treatment. It may not escalate the cost of side effects or other things, but that should be kept in mind when you are dealing with a patient from a developing country scenario. And then also the patient's acceptability. And then there are certain individual side effects which can happen in situations like dealing with the patients of the reproductive age group and other kind of issues also should be taken into consideration. So finally, there is no absolute answer. I mean, you will have to translate the information available to an individual patient in which additional factors should also be considered. That's the way I would like to approach. So both of you are right and I mean wrong both ways. Both ways, it is that's when you try. That's what my opinion is. I would like to hear from others also. That what their viewpoints.
Sir has effectively ducked the ball and has not chosen one hand over the other hand. So, but that is
it's a brilliant summary of.
So what sir was trying to mention is that it is what is the response to the first drug and the reason of failure of the first drug, which usually determines what the approach you should take. That will be one of the important factors. Atma, what is your thought or what you do? Any you want to comment on that?
I agree that one approach is something like comfortable zone, and other is like trying the kind of coming out of comfortable zone. But yes, at times, like we start the second drug and see the response, and suppose the response was very poor with the first drug and very good with the second drug, then we can easily continue the second drug and stop the first drug. In those scenarios, monotherapy is easily achievable. The problem happens if suppose first drug has some response, and after adding the third drug, then now the response is good. Whether then we can remove the first drug or not. So as sir mentioned that lamotrigine was added with valproate, and if we continue only lamotrigine, it is possible that valproate might not be required. So those scenarios are something where monotherapy may be definitely a preferable choice. But yes, no doubt that combination therapy is the most common thing being done.
But that is, I think, that is what we want to change. It is not like we will give some consensus maybe subsequently.
Yes.
But the same thing highlights that we have to individualize the therapy. So if anyone else wants to add, anybody in panelist, anybody else is there? I don't know. There are some name written as doctor, but I know Neeraj is there. Or
Sir, there is one question. Will artificial intelligence help in this decision?
I think that's a very good question. Like I think two scenarios which might help us in the future decision making regarding the anti-seizure medication therapies. Number one, perhaps, is pharmacogenomics,
Yes, sir.
where we'll be able to. I mean, it's only available for very limited number of pharmacotherapy situations in epilepsy, other than let's say carbamazepine induced the cutaneous reaction, and maybe something related to treatment. I mean, the treatment in Dravet syndrome. These are the sodium channel the syndromes. These are the only things available. But the future, we may look upon the pharmacogenomics to play a big part, not only in the drug responsiveness, but also in the drug adverse effect. So that might help us in perhaps choosing the correct first drug and then appropriate second drug and all those kind of things. And the second scenario is based on the big data available, whether the artificial intelligence and whether that will help you to decide on algorithms, which are the situations in which you would like to go in for a sequential monotherapy versus a duotherapy. That might also be possible. So these are the two things to look upon. But till then, we'll have to individualize the decision to the patient who is sitting in front of you, after discussing with him the different scenarios, and make the choice which is acceptable to you and also acceptable to the patient. Here, when I just wanted to put in another point also. Let us say that second or the third or the fourth sequential monotherapy, will that delay the diagnosis of drug-resistant epilepsy? That is again a point to remember. For example, you make the diagnosis of drug-resistant epilepsy where two drugs have failed, either sequentially or in a combination. But when you use these 3 or 4 monotherapies, will that result in the delay in the diagnosis of drug-resistant epilepsy? That's another issue which can be brought up also. That.
But sir, in that case, the definition is very clear. Failure of the two sequential drug trials, whether it is in monotherapy or in the duotherapy. So as far as that is considered, if patient has failed two sequential monotherapy, still you can consider. Although we would, as a practical point of view, probably we would like to use a combination therapy. But as far as the consensus definition clearly suggests that if you fail the two therapies, monotherapy also, it will be a drug resistance. Now, so another is whether it is what the first drug has failed. Let us say if the first drug which has failed is let us say in the partial epilepsy, or sorry, in the generalized epilepsy, the first drug failed is levetiracetam. Versus another patient where the first drug failed is valproate. Now you know that efficacy is different. In the case of whether the levetiracetam, we have clearly shown that valproate has a better efficacy in this levetiracetam. So I think that is one of the very important choice we have to make. What is the first drug which has failed? So drug which has failed, it is very common practice in the clinical that a majority of the clinician or even the neurologist mainly use second generation drug, either lamotrigine or sorry, nobody's using lamotrigine, levetiracetam or vildacetam as a first drug. And it is a common practice in India all across. I think 80% of the neurologists will start levetiracetam as a first drug. So that also gives us a very important point that you would at that point of time, whether you want to switch the drug or whether you want to add the drug. So in that case, my opinion is obviously when you have a less efficacious drug has failed, obviously you would want to add another drug, but you will try to more efficacious anti-epileptic drug, isn't it, sir?
I think largely it is true, but one should also remember that then again, we are translating it from a group of patients to an individual patient. For example, responsiveness in an individual patient for the same drugs could differ. For example, there are patients with benign localization related or self-limited epilepsy syndrome who may respond to valproate and versus oxcarbazepine. And we have seen both ways. They did not respond to valproate, then you start oxcarbazepine, they have responded. And some of them who have failed oxcarbazepine has responded to the valproate also. So there is a lot of inter-individual variation in the responsiveness. This is where pharmacogenomics might play a role in the future regarding how to individualize the treatment, whether you are using it as an initial monotherapy or a second line monotherapy or a combination and all. These are going to be governed in the future to some extent by means of the pharmacogenomic data.
Okay, so I think if there are, let us try to usually whatever we have discussed and this, let us see we can reach some consensus. I will be showing some slides, and it will be mainly what I practice usually over the years and what I have learned. So, okay. So, whether basically the factors which we have to consider and while choosing the therapy is what is the reason of failure of the first drug, and that is if patient failed because of the inefficacy or because of the side effect. So that is one of the factors which decide us to choose one of the approaches, whether the alternate monotherapy or duotherapy. And second was everyone has mentioned what is the effect of the first drug. Okay, whether there was a partial benefit. If the drug has benefited to some extent, and sometimes it is difficult to judge in a given patient. Suppose a patient had only 2 seizures in the past, and now you have started on, let us say, levetiracetam in the adequate doses. So now a patient has maybe 1 or 2 more seizures, you increase the dose. So you really don't know whether it is a partial benefit or no benefit. But that is if a patient has a higher frequency of seizures. In those cases, obviously, you will be able to know whether there is a partial benefit or no benefit with a particular initial monotherapy. And then what I was pointing that not all drugs are similar. So obviously that I also very often use in my practice. So that we have to individualize the approach. If the patient has failed or the first monotherapy has failed because of the adverse reaction, you have no option but to switch to the alternate monotherapy. But if there is failure of because of the no efficacy, in that case also we have to switch to the alternate because that drug is not working at all. But if there is a partial efficacy, then probably in that case you would like to add on the therapy and see how does it work. So this is the usual approach is what usually we do into the practice. But another important approach I follow in my practice is what is the nature of the drug which has failed. So in my practice, I realized that lamotrigine, levetiracetam, and lacosamide, both for the partial and focal epilepsy, are less efficacious than the carbamazepine and valproate. So if those drugs has failed, invariably I will go for the alternate monotherapy. Although this is dogmatic, but with some intra-individual patient variations, but majority of the cases, in those cases, I would try alternate monotherapy. But once the patient has failed the carbamazepine and valproate, I know that none of the other drug in a single monotherapy is going to work, although with few exceptions. And in this case, usually I go for the add-on therapy. So this is how I have, over the years, tried to individualize the therapy. And this is how we do it. So there are maybe 2 approaches. You have a drug A, and you have a drug B. So you continue the drug A in the same dose, gradually build up the drug B, and once it reaches the maximum dose, you try to taper off the drug A and continue with the drug B. So this is usually what approach we follow. This after doing for the alternate monotherapy. So that's thing I think with that particular, with this, I think we can have at least some consensus that what kind of approach should be followed when we have a failure of the first monotherapy. So obviously to highlight again that there are obviously no straight answer, but in spite of these controversies, definitely we can reach some consensus where to use alternate monotherapy and where to use duotherapy. Okay, so if suppose
Thank
there
you,
are
sir. It was very informative, sir. Thank you.
Mm.
At least some consensus are there for us to approach.
Yeah, so
Oh,
that is what I have been practicing, and this is what I
okay.
have been doing in this. And so I think we have heard from everyone.
Except that there were no much comments from the participants. So I was looking forward to some of the comments from them, and other than the speakers and Atma and myself, we didn't. But Sanjay, what do you do? Because you're not audible. Your mic is
Unmute. Sanjay
unmute.
bhai,
Me.
unmute.
Yes, sir. Here I am learning, sir, with you all experienced.
I hope you learn the correct things.
I think Gagandeep sir could not join, and I think Murthy sir also did not join. So we have
Sir,
to.
he joined in between. He came for some time.
I think JMK was briefly. I
He
saw
was
him.
there, sir, for some
I
time.
mean, you could even find out whether you would wish to make any. Gagan, I did not see.
I think he was not available, I think. So.
Okay, JMK was there for a brief period. I mean,
Yes, sir.
but I was looking forward to more comments from the participants. Like
Kalyani, sir,
who
Kalyani wants to
attended
comment.
and attended.
Sir, Dr. Kalyani wants to comment, I think.
Sure, welcome. And in between, there was I think Dinesh or the Chadurbuti could take it. I could see one of the questions which was asked about whether is there any EEG criteria which you use in selecting the first drug and the second drug, and there was some question like that, or it's only based on the epilepsy syndrome. So how do you like to answer that question?
It's actually a good point.
Sir, 1 second. This support is. Can you promote Dr. Kalyani Karkare? Is it possible to promote her to the panelist?
Yes, sir, I can do that. Just allow me 1 second. What was her name again, sir?
Kalyani,
she has raised the hand. So Kalyani.
Okay. Just give me 1 second, please.
Okay, sir. Naik sir, please proceed.
It's a very interesting point, and we have seen this practically also happening. That just take, for example, the self-limiting epilepsies of childhood, classically benign or Rolandic epilepsy, centrotemporal epilepsy. Now, we know that carbamazepine is effective. We also know that valproate is effective. But if you see the spike burden in the sleep EEG in the BRE, and you find that there are lots of spikes, there's a marked activation of discharges during sleep, where the child is otherwise normal. Now, if you use carbamazepine, there's a possibility that it could, aggravate the condition. So yes, so that would become, I would definitely avoid carbamazepine as a monotherapy in that case. I would choose, say, valproate or another drug. So in that sense, EEG is very, very useful. This has been our practice. So we try to avoid sodium channel drugs in patients who have their interictal spike burden is high, and use other drugs, broad spectrum drugs. That has been the any comments from others? I mean, this is how I've been practicing, and we have seen this happen. You just withdraw the carbamazepine or oxcarbazepine, they become much better. They have these kind of negative myoclonus, and they have these atypical absences and all that when they are on carbamazepine. It's just straightforward benign Rolandic epilepsy with high spike burden in sleep.
So basically, sodium channel blockers, those narrow spectrum medicine is better to be avoided in certain situations, like obviously in idiopathic generalized epilepsies or genetic generalized epilepsy, probably benign epilepsy of childhood with high spike load, and probable epileptic encephalopathies. So that is what I think, based upon that easy finding, sometimes we can do it. Kalyani, you want? Yeah. Yes?
Yes, sir. Hello, sir.
Yeah, please.
Yeah. So I think, yes, I mean, I'm more in favor of alternate monotherapy. That's the way I do. most of the time. And the same way, like if someone is on levetiracetam and I feel it's not so efficacious, so I change it over to valproate or whatever suitable drug is focal. And if they are on valproate or carbamazepine, then I already know probably I have to add another drug. So that's the way it works. My only issue comes is people come to us with levetiracetam and clobazam combination. I mean, clobazam is kind of a drug which people are using, abusing so much. Like they start because most of the probably neurologists or other doctors know that levetiracetam is not that efficacious. So they add clobazam and then they send the patient. Now the patient is well controlled on levetiracetam clobazam combination, but it has been added like a month back. And sometimes they use clobazam like a rescue, like the seizure has come, another 5 days you take clobazam and stop. So those kind of practices are also a lot. So if I feel that it's a typical genetic generalized epilepsy, which or GTCS on awakening or something, which can easily be controlled by a single drug like levetiracetam, I kind of dare to reduce the clobazam, but there I always feel that I am the one now who is withdrawing the patient from dual to mono. So that is, I think, currently the more, I mean, I always receive patient already on duo, and which need not be there. So sometimes it becomes tricky. If you are the one who has removed and unfortunately they get it, which may not be actually causally related to your withdrawal, but that is something, is a kind of practical question which happens.
Okay, so two things, Kalyani. One is that you are not lazy, and secondly that you see probably not 100 patients in a day. So
No,
those gives you an option of alternate monotherapy, which I was advocating. But this is a situation, and then probably at the same principles will remain same over or more or less the same. We always have this fear of that patient gets another seizure or losing the patient and all these things. But if we follow the same kind of principle, what we overall for the control of the epilepsy, I think majority of the situation we will be able to wriggle out. But that situation is quite common. Patient has already been started on duotherapy and you wanted monotherapy and this. So in majority of situation, I will also try to, if the patient had really was not responding to the levetiracetam and now has, after adding clobazam, patient has responded, then probably I will not do anything. Okay, let us continue the same, because patient had responded to the clobazam. It may be a combination of the clobazam. But if there are two drugs, there is very common practice that some people start two drugs from the beginning after the first or second seizure at the initial. So in that situation, obviously, you would like to change to the monotherapy, isn't it?
Yes.
But I think that each level, as Kalyani mentioned, that it is important to counsel the patient properly, that he should be prepared for that. And that's what I mentioned, the so-called acceptability from the patient and the caregiver's point of view. That's extremely important. Otherwise, they'll be very disappointed. The patient is on a duotherapy and is controlled for 3 or 6 months. And then you try to withdraw the medication and the patient gets a seizure. That most likely that patient may not come back to you after. So that's also, they have to be taken into picture, the risk and other things associated with the recurrence. But then you have to also mention how the duotherapy can produce more side effect if it is happening in that patient and other things. So these are the situations you will have to largely individualize the point. Dinesh, you were discussing about the EEG. Suppose a patient has got, in addition to the spike burden, if there's an associated photosensitivity, would that also make
sodium channel drug? Yeah, certainly. Yes.
Yeah, I think that's also
absolutely.
another point.
So photosensitivity would be a strict no-no with the, yes, absolutely true, sir. So I think EEG is definitely a very useful marker for choosing the right anti-seizure medicine as the first. I think multiple factors have to be taken into consideration.
And I think future genetics will play a big part, like what happens in SCN1A mutation and SCN2A mutation. You know, the drug which is going to exacerbate and the drug which is going to be beneficial, and those things are, I mean, they will be helping us quite a lot in selecting and individualizing, and also both for monotherapy and duotherapy and everything.
There are some questions, but I'm afraid we already have reached 9:30. Maybe very briefly, I will answer two questions which are, I think, important. One is, this is the question and answer session. How long one can keep increasing the first drug? The patient has partial control. That means when you call that first drug has failed. So that obviously, it again has to be individualized, but dictum is that you try to the maximum possible dose till the patient experiences side effect. So that is what is the usual book says. But practice, it is not like that. Usually there is a ceiling dose of majority of the medicine. We have a ceiling effect. So for me, if the patient has reached 800 or 1000 milligram of carbamazepine or 15 milligram of 1500 milligram of levetiracetam, and if it is having seizures are not controlled, then chances of further increasing the dose, usually chances of becoming seizure free are remote. So that usually comes with the experience that what can be the ceiling dose and this. But for the practice and practical purposes, you try to increase the dose till what is the maximum daily defined dose, or if the patient experiences side effect. And whether the valproate and lamotrigine combination is useful for both focal and generalized, yes, it is very much. It is useful in focal epilepsies as well as in generalized epilepsies. So I think with that,
I think the additional point to make is, I think the question was possibly intended how long you will wait for the duration after you have titrated the drug. How long you wait to decide whether the seizure control has been achieved or not. I think here you can take the support from the definition of the drug-resistant epilepsy. Usually the interseizure, the shortest interseizure interval multiplied by 3. Suppose it is something like 1 month or 2 months in between. It may take at least something like 3 to 6 months waiting before you decide that a particular drug is effective. That's the one which I usually use based on the definition regarding the duration. But these are all arbitrary for a patient who wants an early control and is not ready to wait for that thing. You can possibly individualize that also. But that definition gives you some kind of a guide. 3 times the interseizure interval can be used as a predictor to predict the duration of treatment which is required to decide about drug responsiveness versus drug resistance.
Okay, so we'll take the last poll to see whether the results have any changed. Can we launch the poll for the last time?
Sure, sir. Just 1 second, please.
Now we have reached the consensus, so I hope it should be 50%. Okay, I request everyone to vote once again for the last time. Your preferred choice: duotherapy, substitution or alternate monotherapy, or refer to an epileptologist. Please vote so that these are anonymous poll. Nobody is going to know. Once you think that a sufficient number has voted, we can have the results.
Still only 35% have voted, sir.
Okay, request everyone to vote, please.
You may wait up to 50%. Or equal to the nearly equal to a number of previous 2 results were decided. I mean,
otherwise it will be something like selection bias.
Yeah, that's right.
Okay, we can see the results now.
Sure, sir. Just 1 second.
Okay, sir.
Oh,
See,
you won the battle. I think that's
but
wonderful.
now, sir,
Yeah.
only 24 people have voted, so that is
Whatever, but you have. I think this is the first time it's got reversed dramatically.
that was a selection bias, because I think many people have already left the session.
No, but even then, there's a substantial number of people there, and I think it's a great debate. And actually, I'm for substitution monotherapy, so that's
Yeah,
What I
basically
do,
the point is,
definitely
I
no.
think they have,
We have to argue for.
what I conclude from this is that they at least knew that you'll have to individualize and there is no single answer. Absolutely.
That's what it is.
That's what.
Very good.
That's what
There's a
it's
role
saying.
for both. Yeah.
I think I thank you,
Wonderful.
Nayak sir and Radhakrishnan sir for joining and enlightening us. I will invite Mr. D'Souza, the head of the Astera division of Intas, to propose a vote of thanks.
I think that interseizure interval is the longest interseizure interval and not the shortest. I made a mistake there.
Yes.
Anyway, good evening, doctors. Am I audible?
Yes, you are audible. Please go ahead.
At the very onset, I would like to thank the speakers, Dr. Dinesh Nayak and Dr. Chaturvus Rathore, for participating in the online debate titled The Next Step After Failure of Anti-Seizure Medicines, Monotherapy, Duotherapy versus Alternative Therapy, wherein they both have vociferously justified their respective stance on duotherapy and alternative therapy. I would also like to thank the valued contribution of our expert panelist, Dr. K. Radhakrishnan, who's a stalwart in the field of epilepsy, as well as Dr. Atmaram Bansal, who have added the rich clinical experience to further augment the benefits of learning from tonight's debate. My heartfelt gratitude once again goes to Dr. Chaturvus Rathore, who so efficiently donned the dual role as speaker as well as moderator, and has brilliantly summed up the salient take-home messages so relevant for clinical practice. I also wish to thank the online participation of all the doctors present for today's webinar, without which this program would not have been a grand success. A big thank you to all of you for being present every second Friday of every month, the next being scheduled for 9th June. Thank you and good night.
Thank you.
Thank you very much, Mr. D'Souza, for all the logistic support, and we appreciate your logistic support from the Astera division of Intas. Thank you very much.
Thank
Next,
you very much. Thank you.
Next debate will be not on epilepsy. It will be on I think movement disorder, and Dr. Soham will be moderating that. So we look forward to that next debate on the movement disorders. Thank you very much.
So, thank you and good
Thank
night.
you very much.
Thank you, sir.
Good
Thank
night.
you very
Thank you,
much.
sir.
Thank
Thank
you.
you so much, sir. So there are mostly 432 participants today.
Oh, that's it.